You need me? Oh. Just a second. You know, June is Alzheimer's Month. It's Alzheimer's and Brain Awareness Month. 10,000 Californians live with Alzheimer's. It's the 5th leading cause of death in California. It amounts to over $3.3 billion in Medi-Cal spending. It affects 1.5 million California family caregivers. And there's no known cause. There's no known cure or prevention. And that's the focus of our hearing today. Promoting prevention and advancing research. Investing in research and prevention now will cost our state far less than the cost for the rising number of people who will be affected by Alzheimer's in the coming years. I'd like to introduce to you our first panelist, and before I introduce the first panelist, I'd like to say thank you. Many people know that I'm a caregiver, and I take care of my husband even though I do this here. He has another caregiver. So when I get home, I may take this award to him to say thank you. But I thank the Alzheimer's organization today for presenting me with a Champion for Caregivers Award for this year, and I thank you. And most of us are wearing purple today in some form or fashion, and that is in celebration of the recognition that June is Alzheimer's and Brain Awareness Month. But the person who's been working on this subject for many years now, and I am very impressed because he's shown us that he's been able to help some of those patients. He's Dr. Dale Bredesen. He's internationally recognized and an expert in the field of neurodegenerative diseases. His research focuses on the mechanism of cell death in the nervous system and has led to a new approach to Alzheimer's disease therapies. Dr. Bredesen,
Thank you, Madam Chair.
Proceed.
Thank you very much. Thanks to you and thanks to the rest of the council members for your support of this area and for recognizing the critical nature of preventing dementia in the state of California and elsewhere. So as you know, it's often said that there's nothing that will prevent, reverse, or slow the progress of Alzheimer's disease. It's also been said that everybody knows someone who is a cancer survivor. No one knows an Alzheimer's survivor. And what I want to show you today is that this is changing. The dialogue is changing. Can you hear me okay? Will do. Okay. How's that? Is that better? Okay. So the dialogue is changing, as you know. We're often told the number 5.2 million Americans have Alzheimer's disease, but that actually is a somewhat misleading number because the number that you really want to know is how many of the current 320 million Americans are destined to get Alzheimer's during their lifetimes. Of course, when we quote the 5.2 million Americans, that doesn't tell us anything about the teenagers and the 20-somethings and the 30-somethings. So what you really want to know is how many of the 320 million currently living Americans will get this disease. And it's about 15% of the population. So it's a staggeringly high number, about 45 million people. And since, as you know, Californians represent about 12% of our nation, we're looking at approximately 5 million Californians who are destined to get Alzheimer's disease during their lifetime. In 2014, it was pointed out that Alzheimer's disease has become, by some estimates, the 3rd leading cause of death in the United States. And of course, in 2011, this led President Obama to sign into law the so-called NAPA, the National Alzheimer's Project Act. And so for the first time, there is a national plan for Alzheimer's disease. And unfortunately, of course, that doesn't tell us how to cure it. And what President Obama has said is that he would like to see by 2025 something that is 25% better than we currently have. And of course, for people who are in the early symptomatic stages, that is a long, long time to wait. As you know, women are actually at the epicenter of this epidemic. Women represent about 65% of all Alzheimer's patients and about 60% of all caregivers. So that if you are a woman today living in the United States, you actually have a greater risk to develop Alzheimer's during your lifetime than you have to develop breast cancer. So it is becoming an increasingly common problem. And at the same time, as you alluded to earlier, we have no cures. So the question is, what do we do in our state? This is arguably the greatest challenge for our healthcare system and for aging, and arguably the area of greatest failure of biomedical research. We have treatments for cancer. We have treatments for heart disease. We haven't had good, effective treatments for neurodegenerative illness. And if you look at the therapeutic landscape, you'll see a couple of very obvious problems. So here are drugs that are in phase 1, phase 2, phase 3. And what you'll see very quickly is that these are all monotherapies. Even though we learned the lesson from HIV, which is that one drug doesn't always do the best you can do, and certainly there's no question that Alzheimer's disease is more complicated than HIV. And yet, look at all the trials that are ongoing here. These are all trials of single therapeutic agents. Even though that's unlikely to be the best way to go, you can also see all these ones that have disappeared along the bottom here are ones that have already failed in their respective trials. And at the top here, you can see that the already approved drugs only represent 2 different types of drugs. So in fact, thank you very much. So in fact, this is a real problem, and we need to look very carefully at the underlying causes of this disease. Here you can see that just in the last few years, one after the other has failed. And as a simple example here, you'll see this one, semaglutide. Lilly paid over $500 million to develop this drug and to test it. And not only did it turn out that this does not make Alzheimer's disease better, it actually makes the disease worse. So there's something fundamentally missing. And I echo your earlier point that we need to develop active prevention and early reversal. So if you wanted to develop the perfect Alzheimer's drug, what would it do? Here's what it would do. It would have to have many, many different mechanisms. And this is one of the reasons that it has been so difficult to screen for a single drug that does everything for Alzheimer's disease. It's a little bit like trying to put one patch on a roof with 36 holes and to think that you're now going to prevent the roof from leaking. There's more to do than you can do with a single drug. So, as I say, a roof with 36 holes, and we have taken a very different approach, as I talked about a year ago in this very room, to look at all the different contributors to the problem. So we really have been left with a fairly sad state of affairs. As you know, patients often do not seek medical care because they've been told there's nothing that can be done. They fear loss of their driver's license, the stigma of a diagnosis, inability to obtain long-term care, and ultimately nursing home placement. Thus, they often present very late in the process, just the opposite of what we'd like to see. And of course, then they finally go to their primary care providers, who often don't refer them since they realize there's no truly effective therapy, and they say, look, we can write a prescription, and why do we need to send this person on to a specialist? And then finally, at some point, if they are sent to a specialist, the specialist will often put the patients through hours of testing, which happens to be quite stressful for the patients, and therefore increased cortisol can actually damage the patient's brain. Expensive imaging, lumbar puncture, then they'll say, well, look, can you come back every 6 months and have a spinal tap, which of course most people do not want to do, and of course they're saying, well, we can't do anything for you anyway. So let me spend one moment here and show you a couple of good news examples. Things are changing, as I mentioned earlier, and this is actually from a documentary that will be coming out next year. Here, and
I am on the slippery slope, and I'm going downhill like a train out of the station without brakes. There's no stopping it. I am losing my mind. I am losing my memory. I am becoming what my mother was like.
You're in a very familiar place. You should know where you are, but I didn't know who I was, why I was there, nor where I was. I used to have to write notes to myself about which side of the road to drive on. I signed up for an online brain training tool called Lumosity. I was in the 30th percentile for my age group.
While I was on the phone, I would all of a sudden start getting headaches. And at the same time, I started to have a hard time remembering people's names.
I didn't say, oh my goodness, facial blindness is a problem. I need to go and see someone and do something about it. I just was like, wow, facial blindness is a problem. How am I going to remember this person? Oh, they have 3 earrings in the left ear or the right ear, right? I'm gonna, like, I do it that way, right? I would find something quirky about the person and try to remember them that way.
I'm going to plan this out. I'm going to see how much longer I'm going to be functional, and then I'm going to make a plan to basically end my life.
And I sought out the best neurologist in my area. And you know what he said to me? He said, good luck with that.
My neurologist was telling me to go to the psychiatrist, take this medication he was prescribing, Lamictal, and see him in 6 months, basically.
When the results came in and they told me that I had ApoE4, honestly, I was completely shocked. Even though my dad has dementia, I just didn't think that I had it.
I mentioned it to a very old friend. She recommended that I see a doctor who was doing significant research, she said. I had no idea that I was actually patient 0.
A member of our website posted a link to Dr. Bredesen's paper, and Dr. Bredesen himself very kindly offered to look at my biomarkers.
I heard about Dr. Bredesen, interestingly enough, from my neurologist.
My sister-in-law sent me Dr. Bredesen's paper. I read it and decided I have to follow this protocol, and I've got nothing to lose.
I do know which wall the light switch is on now. I do call my pets by the correct name. I do get in my car and drive like a maniac across country or wherever I want to go. And I don't get lost, and I don't use my GPS most of the time because I'm irritated by that woman's voice. And when I first started having symptoms, I backed off my work. I couldn't perform. I couldn't write a grocery list, let alone write a complex report and evaluation. There was no way I could do that. I noticed recently on an assignment that was extremely stressful, long hours, 7 days a week. I was working with 3 or 4 people who were half my age, in their mid-30s, and they were napping, they were getting sick, they weren't coming to work, and they were asking me, well, what's my secret? What am I doing?
I landed yesterday at a major international airport in San Francisco and drove an hour to be here with you today, and that was no problem. I no longer need a sticky to tell me which side of the road to drive on. I mean, I'm doing terrific. I can not only read, but I've moved beyond novels to reading medical journals now, and I'm fascinated with them, and they've become my passion.
My memory recall on names is much better. When I play poker, I'm able to recall all the situations, focus better. At work, I'm a little sharper. I lost some of my sexual desires, and that's bounced back. I feel like it's more towards the normal side of what was happening before. I'm happier. I sleep better. My relationship with my wife is improved.
I went to Parents' Day at my kids' school, and it was a completely different experience. I actually had a really good time. And I was seeing people that I hadn't seen in years who had just transferred to the school and with their kids, and I knew their names and everyone's names, and I felt confident to engage in conversation and talk to them. All of a sudden one day, like, all this Russian started coming back. It was really weird, and I was so excited about it that I just started to write every word that was coming into my mind. And it's strange, it's like the channel opened up. And the same is happening with Chinese. This fall, I had to type something up, and I went so fast, like I used to. It was shocking to me. My throat was opening in a way that I thought I had grown too old for, like as if my throat didn't know how to open that way. And it did. And the sound came out the way it had before, and now I love to sing. They redid the cognitive testing, the same couple hours testing battery. He looked at that and he said, based on this, I'm going to say now that you were in early cognitive decline before, but now you're completely resolved.
So just this past week, a paper was published in which we showed objective improvements in additional 10 people. We've had over 100 people come through this program now, and let me just show you a couple of these here. So here's a person who had a hippocampal volume. This was a person with well-documented early Alzheimer's disease, positive amyloid scan, positive PET scan, abnormal neuropsych testing, and you can see here his hippocampal region of his brain had shrunk down to 17th percentile. This person is ApoE4 positive here. Both parents died with Alzheimer's disease, and you can see here after 10 months on a program here, 75th percentile, dramatic improvements also in his metabolism and also in his ability to function at work. Here's another person who was on for 2 years, and you can see here just dramatic improvements in quantitative neuropsychological testing, 3rd percentile here to 84th percentile, less than 1 here to 50th, 54th to 96th, and so on and so forth. Dramatic improvements and unprecedented improvements. This was part of the paper that was just published. So we're seeing improvements that have not been seen before using a multimodal and a comprehensive approach. And here's a person actually ApoE4 homozygous, and somewhere between 50 and 90% of these people will develop Alzheimer's disease. So it is a very common problem. There are about 7 million Americans who are ApoE4 homozygotes and about 75 million Americans who are heterozygous for this. And you can see here in 5 months just dramatic improvements here, 16th percentile, 73rd percentile, and so forth and so on. So the goal here, I think for all of us, is to reduce the dementia in California. If we could reduce this by 50%, we could save around $10 billion per year. So what are the sorts of things that we might consider in this regard? First of all, a program on prevention and early reversal, the California program on prevention and early reversal, something that is now a possibility that wasn't a possibility even 5 years ago. And then here, 2S4A, Too Smart for Alzheimer's, a state program to reduce dementia. What sorts of elements of this program might be considered? Public service announcements. I think we've all been told repeatedly that there's nothing that can be done, and I think that that dialogue needs to begin to change. Secondly, support for testing. People over 45. And what we argue is that just as we all go in for colonoscopies when we're 50 and over, it would be a good idea to go in at 45 for a cognoscopy, that is to say a cognitive assessment, so we'll know where we stand, and we'll know what our metabolism and genetics are, and if we need to get on an early program for prevention, we can do so at that time. Next is that we believe that there is a tremendous return on investment given the current dementia costs. As you know, this is a hugely expensive disease costing the United States over $220 billion per year. And as you know, many interested individuals may be very helpful in this regard. When people begin to realize that there is something that can be done here, I think there will be a lot more help. Just about everybody, as you know, is touched by this illness, whether it's through a family member, whether it's through themselves, whether it's through someone they work with, what have you. And then, of course, training new types of practitioners, training practitioners that are the sorts of practitioners that are looking at the whole picture instead of looking at just one area. And, of course, training what is becoming more and more common, which are wellness coaches, people that don't necessarily have to be MDs, but that can help people with wellness throughout life and therefore reduce problems. So let's work together to reduce dementia in California and around the world, because I think the time is here. We have the tools to do that like we've never had before. So again, Madam Chairperson, thank you very much for the invitation, and thank you for being a friend to those who are at risk for neurodegenerative disease, which is, of course, all of us. Thank you.
Thank you so much. Every time I hear you, I've had people talk about you when you came to my district. I've had people ask me about how you're doing and how your research is coming. So it's good to see you update us on that research. Are there any questions? Well, I guess all my members are gone. Yeah. I think they sneaked out on me, right? Thank you so much.
Thank you again.
Randy Chapman is next, and he serves as the state of... Huh? I'm sorry. And she serves as the Director of State Affairs for National Alzheimer's Association. It's a leading global voluntary health organization in Alzheimer's care and support. It's the largest private nonprofit funder of Alzheimer's research, and she manages the organization's state government relations program, working closely with chapters all over the country. She is a graduate of Vanderbilt, received her Juris Doctorate degree from Cecil C. Humphreys Law School at University of Memphis. She's the proud mother of a third grader and a self-proclaimed Wayne Gretzky supporter, or the next Wayne. That person is that. Your son is that.
So he thinks. Yes.
And she has a husband, Justin. Thank you very much for being here, and please give us your presentation.
Well, thank you, Assemblymember Brown, and to your committee. Thank you for your ongoing commitment to issues affecting the aging elderly population in California, for your specific commitment to caregivers and to those living with Alzheimer's disease. We appreciate that. And I also appreciate the invitation to be here to speak before you this afternoon. I'm honored to be here. I represent the National Alzheimer's Association. As you said, I'm responsible for state government relations in all 50 states, but it is always good to be in California, a state that is certainly notable for its progressive and proactive policies, particularly dealing with Alzheimer's disease and related dementias. So California has been at the forefront on Alzheimer's policy for the past 30 years. Some of the things that you all have accomplished are having 10 university-affiliated Alzheimer's disease centers, Alzheimer's daycare resource centers, a tax checkoff for Alzheimer's disease research that has raised approximately $12 million over the past 30 years, which is really extraordinary. Secretary-level Alzheimer's Disease Advisory Committee, again, something that we don't see across the country. We at the National Alzheimer's Association have our own sort of national state policy priorities, and California has also been a leader in that area as well. You all adopted a state plan for Alzheimer's in 2011. I heard the previous speaker mention our national plan. I'm always happy to say, since I work in state policy, that states were actually at the forefront of having Alzheimer's plans, and so California, again, passed theirs in 2011. You all successfully passed the Uniform Adult Guardianship and Protective Proceedings Jurisdiction Act. You have also appointed a statewide caregiver task force, which we're very excited about. Congratulations on that. You have worked with your Department of Public Health to include questions on cognition and caregiving in the annual behavior risk factor surveillance system. And you've also certainly successfully undertaken a comprehensive revision of rules governing residential care for the elderly, including requirements for dementia-specific training. So again, something we're very excited to see here in California. Excuse me, and I've been told, certainly Chairwoman Brown, that you and your committee are to thank for much of this progress. So again, appreciation for that. You all serve a crucial role. You oversee the Standing Committee for the fastest growing demographic in this state. Your Department of Finance reports that school-age population here in California, ages 0 to 19, will increase by just about 2% over the next few decades, while those aged 65 and older will grow by an astounding 113%. So this is a very important committee of a very important subject that you're dealing with. And with that data point, I want to encourage this committee to continue to build off of the past success that you've had, creating a new system of care that meets the needs of persons with dementia, to prepare for the not-too-distant future, the pivotal year of 2025, when 870,000 Californians will be living with Alzheimer's disease, and nearly 2 million family members will provide unpaid care for a loved one. We need to work together and focus in 6 critical areas: capability, competency, capacity, cost, caregiving, and culture. First, capability. A dementia-capable system recognizes individuals with cognitive impairment early, and the cause or condition is well documented in the patient record. Even in our long-term care system, a model developed exclusively for older adults, it's astounding how many programs and services fail to ask basic screening questions about memory impairment. Older adults are frequent users of health care, yet professionals often miss, dismiss, or even ignore some warning signs about decline in cognition. In our work on a federal grant to strengthen California's coordinated care initiative, we've heard from health plans that they routinely don't know that their enrollees have dementia until they show up in the emergency room in crisis. So one promising practice that has been happening here in California is the universal assessment tool. This holds a great amount of potential for addressing cognitive impairment on the same level that we've historically looked at physical activities of daily living, like eating, bathing, etc. Second point is competency. A dementia competence system understands that Alzheimer's disease is not normal aging. Physicians, nurses, allied health professionals, direct care staff, law enforcement, all of these folks can be trained to detect and diagnose and manage dementia conditions to a degree that's commensurate and relevant to their professional, what they do in their professional lives. At the national level, we've worked with Justice and Aging. That's a group of attorneys based here in California as well as in D.C. that focus on senior legal issues. We've worked closely with them to develop model legislation related to dementia training in long-term care settings, such as home care, RCFEs, and in skilled nursing. Another promising practice here in California is an item that's actually pending in the state budget as we speak. If Governor Brown signs off, there will be $2.5 million in new funding to train primary care doctors in how to detect and diagnose Alzheimer's disease. Again, that's unique here in California and something that is sorely needed across the country. You all know this by now, I'm sure, but fewer than half of all patients with Alzheimer's have even been told of their diagnosis. That's compared with well over 90% of those among leading cancers. The third point, capacity. A system with dementia capacity has a sufficient workforce to meet the needs of the population. Over the 4 to 20-year span that a person lives with this disease, individuals need access to a full continuum of personnel, ranging from specialty neurologists and psychiatrists, to home care aides, in-home supports and services, and everyone in between. Unfortunately, all of these people are in short supply. Many are underpaid, many are undervalued in their important role in providing care and support to the frail elderly. Another promising practice here in California is the three-way contract language adopted between the California Department of Health Care Services, the Centers for Medicare and Medicaid Services, CMS, and each health plan that's participating in CalMedi Connect. The contract pilots a new role, dementia care specialist, to liaison between medical professionals, social services, and community supports. Cost. Around the country, California's costs are the highest. It's not uncommon here to pay up to $25 an hour for in-home care or even upwards of $100,000 per year for private pay skilled nursing. Many families are spending down their savings and assets at record rates, qualifying for Medi-Cal earlier and longer. At present, California spends $3.3 billion annually on Alzheimer's disease alone, and this will increase by nearly 58% to nearly $5 billion within a decade. A promising practice here is the work that's been undertaken by Leading Age, AARP, and the Alzheimer's Association to revitalize long-term care insurance market and look at options that people can pursue in order to plan for their long-term care needs. They're looking at new policy types and new ways to fund long-term care insurance through both public and private models. So fifth, caregivers. With over 1.5 million husbands, wives, partners, sons, daughters, sisters, brothers, aunts, and uncles today who are providing active care for a loved one with Alzheimer's disease, the system clearly relies on unpaid caregivers. And they need acknowledgement, they need support, and they need resources. We applaud you, Assemblymember Brown, for pushing the state task force on caregiving, and we are pleased that our own Edie Yao from our Northern California and Northern Nevada chapter has been appointed to represent the Alzheimer's Association on that task force. We look forward to get to the work getting underway soon, and we look forward to seeing what wonderful policy initiatives come out of that committee. Culture. Here in one of the most diverse states in the nation, we have the opportunity to address health disparities and inequities. We know, for example, that women, as well as African Americans and Latinos, are disproportionately affected by Alzheimer's disease, having 2 to 3 times the prevalence as Caucasians. One best practice, a small beginning, is in the California Department of Public Health's recent award of $1.6 million in the state tax checkoff dollars to researchers throughout the state. 320,000 of those funds are being directed toward health disparities. So in closing, I want to recap the 6 areas where the Alzheimer's Association wants to continue working actively and partnering with this committee, the legislature, and with the administration to build a new system of care that meets the needs of the 610,000 Californians living with Alzheimer's disease and those to come in the future. Capability, competency, capacity, cost, caregiving, and culture. As your state did so admirably 30 years ago in anticipation of the age wave, we urge you to do once again in preparation for the silver tsunami. Just as California built an Alzheimer's infrastructure in the 1980s, disease centers, daycare, tax checkoff, the advisory committee, we urge you to build the next level of support that's needed to meet contemporary needs. Our hashtag for today's Advocacy Day is Alls Together, and that demonstrates our commitment to work with you. Again, I thank you for the opportunity to present today, and I welcome any questions that you may have. Thank you.